Good morning, everyone. Thank you for the invitation by the society. And I was informed that I will speak English and will translate simultaneously. So I will not stop my presentation. I will continue my slide, and then the translator, Dr. Wee, will help the English translate to Vietnamese. Okay. First of all, thank you again for the introduction to me, Dr. Zhang. The first talk is fill the gap of compression fracture, because in Taiwan or in the Western country, there's quite a lot of compression fracture due to osteoporosis in the elderly. So, hello, Da Nang. It's a beautiful city, people-friendly, and welcome to Taiwan, a 101 building and the beach. And the sun, moon, lake, and also the mountain. Okay, 2 slides for a couple of questions, just a film quiz. So ABC, which of the following is the vertebral compression fracture? Take a few seconds. I don't have answer right now. So the second one, same. Which one is related to osteoporosis compression fractures? So you can check the cortical bone, check the bone mineral density. Okay, so compression fracture actually is not only the feeling, it's not only the intuition of the interpretation. Still, we have definition. We have 5 gaps. I raised up 5 gaps, perhaps more than that. So the first one is how to define a vertebral compression fracture. So compression fracture is compression fracture, but how do we define it? So first of all, we have to memorize Dr. Harry Jeanette, who is my boss, my mentor 30 years ago. He actually investigated the grading of vertebral compression fracture. The purpose of this is to monitoring the degree of severity after series of follow-up. So this is the purpose. He never mentioned the term compression fracture at that time, during 1992 to 1996, I guess. So grade 1, grade 2, grade 3, different degree. As for grade 1, is 20 to 25 degree of reduction in vertebral height. He never say it is compression fracture. Okay, the purpose of this is to monitoring patient with a degree of reduction of vertebral compression due to osteoporosis in several years follow-up. So this is the purpose. So the purpose of this is not for diagnosis only, okay? So now he mentioned grade 2 or grade 3 can be defined as osteoporosis, not grade 1. Okay, this is the first slide that in 1992, he made a pencil pinpoint of 6 points so that we can easily identify vertebral compression fracture in a series of images. Go from the left. Here we can see the grade 1 fracture, a grade 1 deformity, grade 2, and grade 3, so that we can monitor the plan X-ray, whether the patient have progression of the disease or not. Okay, now, without the 6 point, now we can see on the left side, here we can see the end plate disruption. This is grade 1 fracture. And in the middle, this is grade 2, is over 25% reduction. And this is grade 3, of course. It is almost collapse. So now, the first definition is the grading of grade 2 or grade 3. The second definition is by modified Yoshida. We can see the left side cortical break. We can see different morphology of cortical break from protruding, intended, disrupted, and proud. And also we have end plate fracture, something like that. We have 3 different types. So the second definition, we have to trace the cortical bone so that we can see the disruption of the end plate or the cortical bone in the anterior vertebral margin. That's the second definition. So now we have two definitions. One is the quantitative vertebral height, over 25% vertebral height loss. The second one is the morphology. Okay, now we have the morphology. We can test ourselves. So we can see the end plate disruption. That's the definition of osteoporosis. Here is our case, a 44-year-old woman has a slip and fall injury. Can we see any compression fracture? She complains of a very severe back pain. So after that, we do MR imaging. We can see on T1 low signal, on T2 high signal, and we can see also the cortical disruption over here with bone marrow edema. So if we use the genetic grade, this is only grade 1, not defined as osteoporosis. But if we can see the end plate disruption, it is osteoporosis compression fracture. So for the end plate disruption used in grade 1 also is the definition. So now we have three definitions. First, genetic grade 2 or 3, without any end plate disruption or with any end plate disruption. The second definition is end plate disruption without any height reduction. The third one is grade 1 vertebral height reduction with cortical bone and plate disruption. So we have three definitions. Okay, now we add one more. In men, as we can see the normal curvature, we also have a wedge shape and over 30 degrees of reduction, which is normal, especially in some occupation, taxi driver, for example, bending the position for a long time is over 33% reduction. It is significant. It's not 25% only. So in men, if it is wedge-shaped deformity within 33%, it is normal. If over 33%, it is defined as vertebral compression fracture. So the situation is a little bit complicated. So we have at least 3 definitions or 4 definitions. Again, height reduction 25% or more. Second, end plate disruption plus grade 1 fracture, grade 1 reduction. The third one is for men, wedge shape over 33%. That is very important 3 definition for the vertebral compression fracture. Okay, so we close the gap here. We close the gap. Before this lecture, this is really confused to the society, even to the world. And now we close the gap. Okay, that's the true definition. The second one, what is the significance and the evidence for grade 1 fracture? Okay, this table is a little bit complicated, but just make it simplify. We can see the 1,500 men, 1,500 men, and we can see group 2 and group 5, that's okay. We predict the second fracture. So these people have the first degree of reduction could be, and then we predict any second fracture. If we use only grade 1, then we have only 3%. If we use grade 1 plus end plate fracture, it's jumped to 9%. So a group with end plate fracture, a group without end plate fracture, both for grade 1, then for end plate fracture with grade 1, it predicts 9% people with a future second fracture. As we know, for the second fracture, 20% will die due to the complications, okay? So this is a very serious problem in the Western country and even in Taiwan. So the grade 1 plus end plate fracture is very important. As for women, also 1,500 population, we can see without end plate, just predict 2%. With end plate fracture, predict 8% of people with the second fracture. So again, for women with second fracture, over 1/5% of people will die on the second year. So all these are very important to look at end plate again. So the end plate fracture is a very important issue that we need to identify on the X-ray, no matter if it's the spine X-ray, a chest X-ray, lateral view, or from the CT scan. Okay. Grading plus end plate fracture, the second gap. The third one, actually beside the number, it's not number 5, it's number 3. How to screen patient with vertebral compression fracture. Okay. As we know, for the chest X-ray lateral view, we can identify so many vertebral compression fracture in the elderly, but unfortunately, almost 40% we didn't report it on chest lateral view. This is the first paper published in Archive, Internal Medicine, very, very high impact factor in 2005. So this alerts us to report compression fracture on lateral view, especially in the elderly. As for the vertebral body compression fracture for the abdomen CT, again, because dictating the abdomen CT is for the GI people, it's not for the bone people. So most of the radiologists do not report the vertebral compression fracture. Almost 84% miss on abdomen CT scan. And how about the hip fracture? Even the hip fracture, when we look back, there's still 41% already has vertebral compression fracture. And almost half of them, 54%, were unreported. Okay, so many cases are misdiagnosis on the initial radiograph, no matter it is chest or abdomen CT scan. So now, for the AI industry, last year in FDA, there is a product we can automatically reformat the image from axial scan to sagittal one, and then automatically capture the compression fracture. This is the first FDA clearance in the world for the automatic capture of vertebral compression fracture. And also, I also have a product last year, and now I just received the US patent for the smart bone, also have automatic capture of the vertebral compression fracture. Okay, so close the gap. Number 4, how to report the vertebral osteoporosis compression fracture precisely. Actually, I just developed 4 points. First, we have to identify the level, of course, the shape, whether it is wedge shape. Remember, wedge shape, over 33% of reduction for men can be significant for osteoporosis compression fracture. If it is not 33%, it is not. And also the end plate, we have to identify the end plate, especially on the lateral radiograph, and the severity of high loss. That's by genetic grade. Okay, so for the diagnosis, we need to identify all these terms, and then we reporting on the report. So close the gap on the reporting. So finally, how to treat the patient. When the patient comes to your clinic to have painful back due to osteoporosis compression fracture, the painful sensation usually have a band-like sensation, something like on the sketch diagram over there. And we can use vertebroplasty. I'm not quite sure in Vietnam, is it common to use vertebroplasty? But in Taiwan, before a few years ago, it's very common, but now it's not common because of the so many complications. So anyway, balloon kyphoplasty also can be used, and a little bit better than vertebroplasty itself. And here we can see on the diagram for the painful sensation drop dramatically due to the implantation of vertebroplasty and also balloon kyphoplasty, significantly reduce the painful score. But is it true? Okay, let's see the randomized study from New England Journal. Okay, look at the conclusion. No benefit effect of vertebroplasty. And even it is worse because of the another vertebra will collapse later on after 6 months. So this is very important. So vertebroplasty itself is does not necessary to prevent further fracture, but could be it can reduce the painful sensation. The painful sensation can be reduced within the 6 weeks. So the time window for vertebroplasty is within the 2nd week to the 6th week. So don't use in the 1st week and never use after 6 weeks, okay? For the 1st week, the patient could be recovered by just medication, the painkiller medication. It's okay, fine. And for the 2nd week to the 6th week, it could be very painful. If we can try vertebroplasty, it's okay. But after that, it is no benefit. Okay, that's the conclusion. The conclusion also supported by this society, okay, including most of the radiology society and neurosurgeon. But it doesn't support by the bone mineral density research society, the biggest society in the United States, regarding the endocrinology and also metabolism. The statement indicate no use for pain relief or even support the current status data. Okay, so it is still argument. So how can we do that? In our hospital, like some other hospital in Taiwan, more than 30 hospitals, and most of the hospitals in the world, we have osteoporosis and sarcopenia center. So for that, we have a clinical nurse. A clinical nurse can service 500 people for the phone call back the patient to come to the clinic, and then take care for the patient for medication after the surgeon fixed their hip or fixed their spine. Okay, usually most of the surgeon, after the vertebral compression fracture or in acute stage or in the hip fracture, they treat the patient by arthroplasty or something. They don't follow up the patient with medication for anti-osteoporosis treatment, no matter it is anti-resorptive or anabolic agent. But now, for this center, we have a clinical nurse, and then we have to cooperate with other departments, including endocrine, and also like radiology, like me, I am also well trained for the endocrinology and also for the osteoporosis. I have a clinic, so we can follow up the patient, start from the screening, start from the fracture to the pharmaceutical treatment to prevent the 2nd fracture. This is very important because for the 2nd fracture, as I mentioned again and again, this could be 20% of people dying within 1 year. So this is the way to fill the gap. So now, take-home message. Is there an osteoporosis compression fracture? Always keep in mind for the elderly, especially for the women. Second, can it be pathologic fracture? We have to identify. This is the job by radiologist. There is any metastasis from other kind of disease. And what's the age of the fracture compared to the previous radiograph? Very important. And standardize the report. Okay, look at the reduction height and also look at the end plate, check the cortical bone, and also the management of acute fracture with painful vertebra. If we want to do vertebroplasty by radiology, by neurosurgeon, whatever, within 6 weeks, don't do it within the 1st week. And check the performance, and if we have good financial budget, then we can, from the institution side, we can top down to set up the osteoporosis and sarcopenia center to support a clinical nurse, and then it is a very good caring for the elderly people. Okay, now the answer is slide number 8, osteoporosis compression fracture, because we can identify the end plate disruption, even though the reduction only grade 1, that is within 25%, 20%. But here we can see the end plate is intact. Even though we can see a depression, it is not compression fracture. This is developmental variant, and here is the sickle cell anemia. The end plate is intact. So the point is the end plate. Here the same. The fracture over here, we can see the depression up to grade 1 or grade 2, and we have the end plate thinning and a cortical break over here. Okay, this is normal. Okay, check the end plate. Thank you for all your attention, and maybe any question later on, right? Thank you. Thank you so much.